Welcome to our in-depth video lecture on contraception for primary care physicians. In this extensive guide, we'll cover everything you need to know: diagnosis, management, procedures, and dosages, from a practical clinical perspective. Unintended pregnancy remains a major public health concern worldwide. By offering comprehensive contraceptive services, primary care physicians play a pivotal role in reducing these rates and improving overall reproductive health outcomes. Before prescribing any contraceptive method, it's vital to perform a thorough patient assessment. Familiarize yourself with the CDC and WHO medical eligibility criteria. These guidelines classify conditions from Category 1, no restriction, to Category 4, contraindicated. Always cross-reference these when deciding on a contraceptive method. Let's walk through each contraceptive method in detail, covering mechanisms, indications, contraindications, and practical considerations. CHCs contain estrogen, often ethinyl estradiol, plus a progestin. They primarily inhibit ovulation by suppressing gonadotropins, LH and FSH, and thickening cervical mucus. These methods can regulate periods, reduce certain cancer risks, but they do carry an increased risk of venous thromboembolism. CHCs are not suitable for patients who have these conditions. Always consult the CDC or WHO criteria. COCs often contain 20 to 35 micrograms of ethinyl estradiol plus a progestin. Start methods such as quick start, Sunday start, or first day start. The transdermal patch is replaced weekly for 3 weeks, and the vaginal ring is used for 3 weeks, followed by 1 week ring-free. Reassess blood pressure within 3 months to monitor for any hypertensive changes. Progestin-only pills are ideal for patients who can't use estrogen, such as breastfeeding women or smokers over 35. They must be taken at the same time each day. Even a 3-hour delay can decrease effectiveness. Expect irregular spotting, possible ovarian cysts, and breast tenderness. There are no estrogenic side effects, and fertility returns quickly once discontinued. The LARCs deliver unrivaled effectiveness and minimize user dependency. Implants and IUDs lead the field in preventing unintended pregnancies. Nexplanon, containing 68 milligrams of etonogestrel, is effective for up to 3 years. Insertion is quick, requiring local anesthesia, and removal is similarly straightforward. IUDs are categorized into hormonal, levonorgestrel-releasing, and non-hormonal copper devices. They primarily thicken cervical mucus and thin the endometrium. These devices can reduce menstrual bleeding and dysmenorrhea, with some patients experiencing amenorrhea. Copper ions provoke a local inflammatory response hostile to sperm. The copper IUD can last up to 10 to 12 years, though it may increase menstrual bleeding and dysmenorrhea. Depot-medroxyprogesterone acetate, 150 mg IM or 104 mg SC, is given every 3 months. It effectively suppresses ovulation but may cause weight gain and bone density changes. Patients should maintain adequate calcium and vitamin D intake and engage in weight-bearing exercise. Barrier methods like condoms also protect against STIs. However, they have higher typical use failure rates compared to hormonal and LARC methods. Spermicides are less effective on their own and are best used in combination with barrier methods. These methods require consistent tracking and motivation. Typical failure rates can be high if not used meticulously. For patients seeking permanent solutions, options include tubal ligation for females and vasectomy for males. Both have high efficacy but should be considered irreversible. Emergency contraception is crucial for preventing unintended pregnancy after unprotected intercourse or contraceptive failure. The copper IUD is the most effective EC, while oral options include levonorgestrel and ulipristal. Tailoring contraceptive methods is vital for different patient groups. Adolescents. Favor LARCs for high compliance. Postpartum women, immediate postpartum IUD insertion is an option. Progestin-only methods are recommended if less than 6 weeks postpartum, especially if breastfeeding. Women over 35 who smoke. Avoid CHCs due to cardiovascular risks. Women with medical conditions, hypertension, avoid CHCs. If blood pressure is greater than or equal to 160 over 100 millimeters of mercury. Migraines with or no estrogen-containing methods. Breast cancer. Prefer non-hormonal options like the copper IUD. Obesity. Most hormonal methods remain effective, but patch efficacy may be lower for those over 90 kilograms. To confidently rule out pregnancy, rely on negative HCG tests and thorough history. Match the method to the patient's preference, efficacy needs, comorbidities, and cost or access issues. Check blood pressure for CHC users at 3 months. Ensure correct usage for all methods and address any side effects. Switch or discontinue if side effects are intolerable or new contraindications arise. One, individualize contraceptive choice based on safety, efficacy, and patient preferences. 2, LARCs provide top-tier effectiveness with minimal user error. 3, CHCs remain a popular option but demand careful patient selection. 4, progestin-only methods suit those who cannot take estrogen. 5, emergency contraception is a vital resource for preventing unintended pregnancy. 6, ongoing counseling ensures patient satisfaction and method adherence. Thank you for joining this comprehensive lecture on contraception. Remember to consult guidelines like the CDC, U.S. medical eligibility criteria, and WHO MEC for the latest recommendations. If you found this video helpful, please like, share, and subscribe for more in-depth medical lectures. Stay informed, stay inspired, and we'll see you in the next video.